can go ahead and take the roll. Becky.
Senator Rocky Adams. Senator Chambers Armstrong. Senator Berg. Here. Senator Carroll.
Here.
Senator Douglas.
Present.
Senator Elkins. Senator Funky Fromeyer. Present. Senator Nemes.
Present.
Senator Tishner. Senator Wise. Present. Representative Bentley. Representative Bratcher. Present. Representative Bray.
Present.
Representative Burke.
Here.
Representative Callaway.
Present.
Representative Camuel.
Here.
Representative Dotson.
Present.
Representative Duvall.
Here.
Representative Fraser Gordon.
Here.
Representative Justice. Representative Neighbors.
Here.
Representative Rayburn. Representative Raymer.
Here.
Representative Riley. Representative Rorks.
Here.
Representative Sharp. Representative Wilner. Representative Witten.
Here.
Co-Chair Senator Meredith.
Present.
And Co-Chair Mosier.
I'm here.
Chairwoman, sorry.
Thank you. Okay. First, I would like to just take a moment to honor our colleague, Senator Johnny L. Turner. He very sadly passed away due to the injuries that he sustained in an accident in September. He will be deeply missed by this body and by his family. And I just ask that we keep him in our prayers, his family in our prayers. And I'd like to take a moment of silence. Thank you. I think the first thing that we will do is approve the minutes from our September 25th meeting. Did everyone have a chance to look over the minutes?
Yep. Second.
We have a motion to approve and a second. All in favor, please say aye.
Aye.
Thank you. The first thing I'd like to do is consider the administrative regs before we lose a quorum to individuals who might have to leave or a little bit early. We have distributed the regulations and the hyperlinks. Does anyone have any questions about the regs that we are considering? Okay, seeing none, I will move that the regs have been considered. The first item on our agenda is an update on colon and lung cancer screening programs, and I'm very excited to welcome our guests today, Dr. Whitney Jones, Dr. Michael Gieske, and Dr. Connie White. If you can make your way to the table, and please introduce yourselves for the record, and go ahead with this exciting update. Oh, and my apologies, Representative Neighbors.
Good morning. I'm Dr. Whitney Jones. I'm a gastroenterologist from Louisville, Kentucky. Almost 40 years in practice now. I'm the founder of the Colon Cancer Prevention Project since 2003, and I have the great opportunity to co-chair the Kentucky Colon Cancer Screening Program and Prevention Program Advisory Committee. Today's comments are on my behalf, and Dr. White is here to answer any questions on behalf of the Department of Public Health, and we appreciate that opportunity. The Kentucky Colon Cancer Screening... Oh, sorry, introduce everyone. My bad. Thanks.
So I'm Dr. Michael Gieske. I'm surprised you got me beat there, Whitney. I've been in practice for 37 years, and I'm the director of our lung cancer screening program at St. Elizabeth Healthcare in northern Kentucky and southeast Indiana. And I also co-chair, along with Tim Mullett, the Kentucky Lung Cancer Screening Advisory Program.
Good morning. My name is Dr. Connie White, and I only practiced OBGYN 20 years. Y'all have me beat. But I retired from that clinical practice. I'm now the Deputy Commissioner for Clinical Affairs at the Kentucky Department for Public Health.
And I'm Representative Amy Neighbors, and I represent the 21st House District.
Okay. Thank you. Sorry about that. So The advisory committee was initiated by statute in 2008, unfunded. We were funded first in 2012, rejected for funding in 2016 to 18, received this back, went through COVID, and so we're here now almost 16 years later, reporting that Kentucky is one of the most improved states in the nation for colorectal cancer, if not the most improved state, large in part due to the work that's been done here. And I'm going to go through our results based upon our mandates. The statute specifically gives us several issues that we were in charge of. We were in charge of increasing screening rates for colon cancer for all Kentuckians, as well as decreasing colon cancer incidence and mortality rates. And when I say colon, I'm also meaning colorectal for those people. We also were mandated to reduce the cost of colon cancer treatment, which I'll show some statistics on, and then finally to administer and deliver the program that provides colon cancer screening for the and underinsured. So that was not our only mission in this activity. So let me talk about our results. Colorectal cancer screening since 2000 up until 2020 has gone up 40%. That's almost a doubling of colon cancer screening in our state. And you can see since 2008, we've gone up a full 12 percentage points. And remember, the higher we get in this screening number, the more difficult the people are to reach. The lowest hanging fruit were already being screened. You know, this program is to help those folks who either didn't have access or didn't have information. So I think in terms of accountability, number one, we've met the mark. In terms of reducing incidence rates, the number of colon cancer cases that actually occur, we've fallen from 68 per 100,000 to 48%. That is a 30% reduction in colon cancer incidence. This means about 640 people each year do not get colon cancer in Kentucky because we found and removed precancerous polyps. And this is where the vast majority of savings that I'll get into later occur. Because as we know, even though treatment for colon cancer is improving, so is the cost of colon cancer treatment improving. And so you can expect a 20% rise in treatment costs for colon cancer over time. So again, the place to invest here is in that prevention piece. In terms of mortality, we've seen a 34% reduction in mortality, and that's from finding cancers that are present earlier than they would have been found had they presented with clinical symptoms alone. And that represents about 250 people whose lives are saved every single year in Kentucky. So I think with regards to the incidence, the screening rates, and the mortality, we have met our marks and our goals in terms of the statutes. In terms of the fiscal issue, I just want to focus down on the lower right-hand corner of this slide. All of this data from the University of Kentucky that I've just shown you was made possible by my co-chair, Dr. Tom Tucker, who I think many of you guys know for many decades has helped guide Kentucky in our fight against cancer, and he produced these slides as well. Our annual savings based on reductions in incidence rates in colon cancer is almost $68 million a year in Kentucky, and those are using very conservative 2010 numbers. And this does not include indirect costs such as missed work, the inability to, going on disability, all of the other issues. These are simply direct costs. So $68 million annually are being saved. And so, again, I think in terms of reducing that cost of colon cancer treatment, I think we have met that mark as well. In terms of our program, let's talk about how it works now. This is the Colon Cancer Screening Program Advisory Committee. This is now a model for many states across the nation because it brings together state entities as well as national entities, along with advocates, hospitals, physicians, providers. The entire healthcare ecosystem now, rather than meeting periodically, can meet on a regular basis and not have to schedule meetings. So again, you see Amy Neighbors, who is our appointee from the House, who's here, but also a variety of people on here. And again, I won't go through the names except to say it is the ecosystem of colon cancer screening and prevention that shows up and has shown up either monthly or bi-monthly since 2008, even during the pandemic. And so, and in fact, I want to mention the great staff of KDPH, Summer Amador, Shelby Van Alstine, Elizabeth Goody, and Dr. White, who keep us in our lanes, if you will, at the advisory committee level and make sure we're aligned with what's going on at the KDPH level. These are partner sites according to area development districts. The ones that have circles are new sites that have been added this year. For any of those who don't see your county represented on this map, I'd love you to reach out to me, and we'd love to meet with your hospital administrators to increase access to particularly central and western Kentucky. Although western Kentucky has an incredibly high rate of colon cancer screening, almost 80%, one of the few areas of the country that's exceeding our levels. So we're expanding. We've gone back and forth, but again, really important that these sites deliver colon cancer screening to folks. And why is that important? Because when we talk about the number of people we'll screen, it's not a huge number, but what really happens is when you're a community health system, when you're a FQHC, when you're at a safety net hospital, and you can't find a way to get a person a colonoscopy, you quit screening people. You quit screening people. So when we talk about the numbers we're screening, you have to understand this is spinning a wheel that's 10 to 50 times bigger out there in the community that allows those folks to get screened, because now they know what to do when an uninsured patient has a need for a colonoscopy, or a patient who has had polyps or cancer needs a follow-up colonoscopy. We can help those folks get it. This is our service program report. I'm sorry I couldn't get the digital piece working, so that's blurry to me. It's not just you. But we screened over the past 4 years about 853 people through the program, found 4 cancers overall. And again, finding those cancers in earlier stages saves tons of money as well as lives. We've had over 20 people with high-grade lesions, which are high-grade polyps or multiple polyps, and probably 30% of those people overall had adenomas in general identified, which are the pieces that we try to remove to actually reduce colon cancer. Our projects that we've worked on this year are messaging in Appalachia, family history, and sporadic history, which we're going to roll into in the piece. And we can get you a non-fuzzy copy of this. I'll ask our staff to do that. But this is what we face in the future. And I, as a Kentuckian, I like pragmatic, proactive measures. I don't like to chase things. And, where we've been in the cancer world, unfortunately, for many years has been chasing it. And I want to let you know what's coming down the road. Young colon cancer is a slow-motion epidemic across the entire first world. And there are only 2 other states that are higher risk than Kentucky. So we're number 3 in this. We're still number 1 in incidence, but we're going to fall off this year. It will be the number 1 cancer killer for people under the age of 50 by 2030. Now, we can either wait on that until it's the number 1 cancer and then react to it, or we can proactively begin to educate both patients, the healthcare ecosystem, payers, providers, health systems, so that we can get ahead of this and have 2030 not happen for Kentucky. And as you can see here in the red, that's Kentucky's rate of early age onset colon cancer. So we're increasing, even though overall colon cancer is decreasing because we're screening, we're increasing, and we're increasing more rapidly than any state in the country except for 2 others. And again, one of the factors contributing to the high colorectal cancer incidence rate is this high rate of colon cancer amongst early age onset patients. It's increasing throughout the U.S. And if we identified this group is really 2 people. About a third of them are people with a family history of polyps and colon cancer. And if we identified those people early enough so they got screened on time according to guidelines, 98% of those people would have had their screening prior to their cancer diagnosis. 98%. And the other 2/3 are people who have sporadic cancer that comes out of left field. They have no idea, presents with rectal bleeding, change in bowel habits. And oftentimes there's a huge delay between the time a young person has those symptoms and they go to the doctor, and then unfortunately another delay from the doctor until a diagnostic colonoscopy. And so really, as we move forward into 25 to 2030, our next 5-year plan, early onset colon cancer is a huge issue, and Representative Neighbor is going to speak to that. But also, as a heads up to you guys as the funders, we have solvency through the first quarter of 2026 for service delivery. And so that will be coming up in the next session. This is not a budgetary session, but I wanted to make sure you guys knew that we were giving you a heads up about where we were fiscally and also where we tend to plan to aim our education and aim our outreach to get ahead of young colon cancer and go on offense instead of defense. And with that, I'd like to turn it over to my friend and KCCSPP board member, Amy Neighbors.
Thank you. As Dr. Jones has already mentioned, I'm a member of the Colon Cancer Screening and Prevention Advisory Board, along with my colleague, Senator Meredith, who also serves on that board. Additionally, I am a survivor of early age onset colorectal cancer, and if you're like me, you may assume that colon cancer is a cancer more commonly diagnosed in elderly males. But since my diagnosis, I've discovered that early age onset colon cancer is on the rise in our state and across the country. 20, 30, and 40-year-olds like me are being diagnosed every day. Unfortunately, for young adults, diagnosis typically doesn't occur until later stages of the disease. I was diagnosed at stage 3 and consequently had to have a colon resection followed up by chemotherapy. The mission of the Colon Cancer Prevention Project is to bring awareness to this disease to all Kentuckians with a special focus on young adults. It also assists Kentuckians who are uninsured or underinsured in getting colonoscopies. And thanks to the funding provided by the General Assembly, this project has been very successful over its 20 years, as we have seen a 40% increase in screenings, a 30% decrease in incidence, and a 34% decrease in mortality statewide. But our work's not done. It is imperative that the legislature continue to provide this much-needed funding and possibly increase it to expand this program in our fight against preventing colon cancer. Not only will lives be saved, but the state will save money overall with the decrease in cost of providing cancer care. I want to thank Dr. Jones for inviting me along on this journey. I'm very blessed to be able to be here today and in a position where I can use my voice to advocate for such a worthy cause. Thank you.
That was excellent. Thank you. So with lung cancer, we have a little bit of a steeper climb than with some of the other cancers. If you look at breast, colon, and prostate cancer there, you can see the improvements that have been made over the last really 50 years or so. Lung cancer is over here on the left. Down the bottom, we have doubled our survival rate, but still 25% 5-year survival rate, but dramatically better over the last 5 to 10 years. And if we look at funding across the nation, lung cancer is the least funded of all the major cancers in the country, and we're trying to change that through policy at the federal level. The story of lung cancer in Kentucky is not good. We're down here at the bottom. We're 56% higher than the national average when it comes to colon cancer mortality. The national average is 35. We're 54.7 per 100,000 when it comes to mortality. But these statistics are starting to improve. This is a more recent slide. You can see Kentucky isn't quite as much of an outlier on this most recent slide from 2024, still 56% higher than the national average, though. Now, when we look at lung cancer rates in males, we're starting to see a little separation beginning. The mortality rate is starting to drop, but males kind of peaked their smoking around 1990. And at that point, smoking rates started to decline, and not long after that, within 15 to 20 years, mortality rates began to decline. And that's solely a result of policy, tobacco legislation, policy, and advocacy. It's no modern miracle of medicine. It's simply policy and advocacy that caused this change to happen. So if we look at healthy trends, declining smoking rates, we can see that smoking rates have declined in black, white, and all races, and Hispanics as well. But very, very parallel trajectories here. If we look at lung cancer mortality trends in the United States, black versus white, there used to be a fair disparity there. But over the last 5 to 10 years, these lines have now converged, and there's really not much disparity when we're talking about black versus white disparity. However, if you look at urban versus rural disparity, there is still a separation there. Males are on the left here, females are on the right, and you can see that there's a fair degree of separation between mortality rates in rural and urban populations. And we're certainly trying to address that through the Lung Cancer Screening Advisory Committee. Very interesting things are happening on a national and international level. This is Doug Lowy. He's the director of the National Institute of Health. I was at the World Conference on Lung Cancer in San Diego a month ago. They have it on a different continent every year. And Doug Lowy gave the opening plenary address. And you can see these were his 4 bullet points, but one of them was lung cancer screening in Kentucky. in front of thousands of people at this international conference. This is one of his slides, a lung cancer screening success story, Kentucky. He highlighted the Kentucky LEADS program, which began back in 2014 to 2016, somewhere in that interim there. And it really began to change the narrative on lung cancer. It resulted in substantially higher lung cancer screening rate and associated disease and late-stage lung cancer, which, as we know, that Whitney addressed, when you have late-stage lung cancer of any kind, it's much more expensive to treat. This is another slide that he showed highlighting the Kentucky LEADS. On the right there, the quills is a quality index that we use for the Kentucky LEADS. That was an original 10 hospital systems across the state of Kentucky. We're getting ready to start Kentucky LEADS 2, and that's going to be another 20 healthcare systems across our state using the quills index of quality. And we're going to continue to improve this lung cancer screening rates in Kentucky. On the right side is a slide that highlights the decline in late-stage lung cancer. I have another slide here that's a little bit easier to see that I'll share with you. This is another slide that was shown at the same conference by a different individual, Roy Osorio-Giobon. He is another expert in lung cancer screening, and he circled Kentucky over here as an outlier because not only are we at the far end when you go along the x-axis in mortality, which is a bad thing, we're at the top end of the lung cancer screening rate, which is a good thing. So we're outliers in a good way there. This is another slide that was shown from another presenter. This was shown by Dr. Norges Flores, and she's another expert in lung cancer screening, and she said, standing on the shoulders of giants, and she highlighted the Kentucky LEADS program as well. So these are some results that really highlight the success of lung cancer screening. This is from our own healthcare system, St. Elizabeth. We're finding about 720 lung cancers since we started our program in 2013, and we're finding 63% of those lung cancers in stage 1. We're finding 73% in the early stages, stage 1 and stage 2, and this continues to get better every year because we bring these folks back year after year for an annual screen until they either hit 80 years of age or it's been 15 years since they smoked. 2023, last year, we found 144 lung cancers, 72% were in stage 1. This year, about 72.5% are in stage 1 so far year to date. This is a stage shift or stage migration chart. And the green bars, that's what happens outside of a screening program. Historically, 50% or more of lung cancers found in stage 4 when people present with coughing up blood, weight loss, bone pain, or some other symptom of late-stage lung cancer. The blue bars are what happens in a screening program. This is our screening program that shows 115% increase in stage 1 lung cancers on the far left, better than a mirror image, and a 77% decline in late-stage lung cancer, stage 4. This is that slide I referenced earlier. For almost 100 years, there's really been no decline in lung cancer mortality. It just continued to go up and up and up, and then eventually it plateaued. And we've seen over the last 6 years a significant decline in late-stage lung cancer, nearly a 19% decline over the last several years, and that's continuing. So that prompted me to look at what was happening in our healthcare system. I wanted to also mention I was at an international conference last week in Nashville, Tennessee, and last year it was in Lyon, France. But we presented this same slide and this same data, and they were just really blown away with the reduction in late-stage lung cancer. So that prompted me to look at what's happened in our healthcare system at St. Elizabeth. The red bar line here is late-stage lung cancers. And over the last 9 years, and this is looking at almost 4,000 lung cancers in our healthcare system, has continued to decline. The blue bars are our early-stage lung cancer, stage 1 and stage 2, and that line has continued to go upward. And those two lines intersected in 2022 and have continued to diverge. We're now seeing almost 57% or more early-stage lung cancers in our healthcare system compared to historically you see about 50% late-stage, stage 4. So that's been a 29.1% decline in late-stage lung cancer over the last 9 years. When it comes to the national screening rate, it's one thing Kentucky can brag about. We are now number 2 in the country for lung cancer screening. This report is put out by the American Lung Association every November. So in about 3 weeks or so, this report will be coming out. I keep hoping we'll take over the first position for Massachusetts, but Massachusetts has some very strong leaders up there with Mass General and Lahey Hospital, and they were pioneers in lung cancer screening. We learned a lot from them. But we're hoping to take the #1 position sometime soon. But this is a testament to what's happened through the Kentucky Leads Collaborative, through the Kentucky Health Collaborative, and for many people in this room that have contributed their time and energy toward changing this narrative. And this compares with the national average of 4.5%. We're at 11%, and Massachusetts is about 12%. Wanted to mention briefly the HEDIS measure that's going to be coming out, and this is going to really help to put lung cancer screening on the map. Colon cancer screening, breast cancer screening, cervical cancer screening, a whole lot of different HEDIS measures. Insurance companies are graded on how well they do with the HEDIS measure. That's an acronym that stands for Healthcare, Education, Data, and Information Set. But insurance companies are given a star rating, 1, 2, 3, 4, 5 stars, based on how well they're doing with these HEDIS measures. They then put pressure on the healthcare system, who then puts pressure on the providers to improve these rates. So this is going to really help. This is probably going to come out, we think, in the first quarter of 2026. We've been working on this for over a year now. St. Elizabeth has been an alpha and a beta test site for this measure, and I sit on the national committee, but this is going to be a game changer. Don't want to get into a lot of detail here, but these are the community programs and partners that we've worked with in allocating and appropriating the funds that you all have been so generous in allocating towards us. And we're going to be working on these over the next year or two. Kentucky Leads Part 2, as you can see, is one of the things on this list. And we're going to really be looking to reach out to more rural areas across the state and continue the improvement and trajectory that we have presently. Thank you very much.
Okay, well, that is fantastic information. It's so exciting to see the work that you're both doing, all of you. And the advocacy is really paying off. So I just wanted the members here and the public to see that we are well aware of the problem, and we are actually taking policy measures to give you the latitude to make this change. I love that you're being proactive and all the early screening. I don't really have a question, but we do have some from the members. And just keep in mind that we have a hefty agenda when you ask your question, Senator Berg.
Good morning. Thank you, guys.
That wasn't directed at you.
Thank you for amazing presentations. And honestly, we are doing good work in this state. Dr. Jones, I do have one question about your presentation, and it doesn't so much have to do with you as with the data. I noticed that most of these numbers go through 2019, and it's now 2024. What do we need to do to improve data collection and disbursement of that information throughout this state? Because 5 years is not perfect.
Well, thank you for the question, and I'll also defer to Dr. White. But the 2023-24 has been collected. It's under review right now in the Department of Public Health. The data I put on our slide was 22 to 23, and that's what's available. We can provide a larger data set. We're in the process of putting that together to be able to prove. And we do an annual report about every 2 years based on funding.
So we are doing an adequate job throughout the state of collecting healthcare data and distributing it to the people that need to know that information. Well, we don't need to improve anything. We're doing good.
Well, I think the advisory committee and the program, collect our data and make that available through our annual report. We're not in charge of sort of broad-based collecting data at the state. That's done at the Kentucky Cancer Registry level,
right,
and through our BRFIS pieces. And I don't know if you want to add to that, Dr. White.
BRFIS, I believe y'all have had, thank you, some information about BRFIS. That's the calls that we do to specialized number of people across the state. It's done every year. It's been done every year since 1985, and ask a whole series of health questions so we can get an overall description of what's happening in the state. That's done each year, and that then goes to the CDC for some analysis. We do some analysis, and that comes out. So that's also on our website. So that's available for people. And we have a lot of hits on that website from hospitals, insurance companies, providers. Lots of advocates especially use that information.
Thank you. Thank you.
Thank you. Senator Fremeyer.
Thank you for this great information. When you shared with us the statistics and how things are improving, I do know we're improving on our smoking rates. But talk me through a little bit from the colorectal cancer and this recognizing that it's happening at a younger age. What are we identifying as the root cause? And then some of the holistic treatment methods.
Right. Well, thank you for the question. There are probably 200 different research organizations trying to understand why colorectal cancer screening, colorectal cancer is increasing in young people. But it is a first world problem. So they have the same issue in Australia and Europe. Again, not so much in third world or second world countries. So that research is ongoing. But we don't need more research to know that it's happening here in Kentucky based on the Kentucky Cancer Registry data. What we do know are a couple things. Number one, we don't do a very good job of identifying people's risk for cancer development early in their life, their 20s and their 30s, because cancer family history is not really, unfortunately, well done in medicine, not in Kentucky, anywhere. So that's number one. Remember, a third of these people could be identified through their family history, receive on-time screening, and have that screening occur before their cancer. We think that it's probably environmental, probably dietary related, but it's really unclear. But the time has passed for us to wait until we completely understand this disease to where we go ahead and start educating people about this process and this disease while we're waiting on the cause. As soon as we figure out what the cause is, we're still going to have to learn to communicate with young people and with doctors and health systems about what it is. But I think that's happening. It's probably going to be multifactorial. I doubt it's going to be one single thing like glyphosate or plastic water bottles. No one knows. But again, our focus is on disseminating that information to young people that they live in a state and country that's at risk. This will be their number one cause of cancer death. They need to be heads up on their family history, improve their lifestyles, as well as early recognitions of symptoms with appropriate diagnostic follow-up. So if I had that answer, I don't know where I'd be today. But I would rather be in Kentucky than any place else.
Thank you. And just on that note, having a family history, I did genetic counseling, and I think that's something that people need to understand is available. So just throwing that out there, that is a screening tool as well. So Representative Camuel.
Hi, thank you, Madam Chair, and thank you all for the presentation. This is great information. I had one question about the lung cancer portion of it. Is there an expectation that in the relative near future we're going to see an increase in the incidence of lung cancer because of the prevalence of vaping? And that includes young kids, because we know it's happening with younger Kentuckians.
Yes, there is some expectation that that will happen. We will see some result of that. Unfortunately, when you're talking about lifestyle changes or things that are put into our environment, it takes about 20 to 30 years to see the impact of those changes. And so we're just at 5 years, maybe 5 to 10, depending on when we start counting exactly into the vaping epidemic. But there is some evidence that's starting to surface that shows a link between vaping and lung cancer and other chronic lung disease.
Okay, Senator Meredith.
Thank you, Madam Chair, and thank you, Dr. Jones, for your commitment to this project for the last 20 years. In a state that measures last in almost every healthcare measure, this has been a bright light for our state, and thank you for your efforts. But my question is regarding the lung cancer portion. Do look forward to that research in the future on vaping, because I think we will see it's got an adverse effect on what's happening. But is one of the reasons Kentucky is an outlier because we have such a high incident rate of radon as well? And how much attention do we need to pay attention to this particular issue, and what do we need to be doing to make people aware of that as well?
Yeah, radon is certainly a factor. When you look at lung cancer, about 80% of lung cancer is attributed to smoking or tobacco use. We think that a large proportion of the other 20% is due to radon. When you put radon and smoking together, it dramatically increases your risk for lung cancer. For example, I know an advocate very well lives in Colorado, Heidi Knapp Menonda, the White Ribbon Project. She developed lung cancer stage 3A at 55 years of age. And she was a fitness instructor, climbed mountains, kayaked, biked, and one of the last people in the world you would expect to get lung cancer. But she worked out in her basement and then found out later that there was a high radon rate there. So it's clearly a serious factor. We've been addressing that at our advisory council and program level, and we certainly intend to bring that into the mix when we talk about lung cancer risk and prevention. Absolutely.
Yeah, I think when we think about smoking, and obviously we've seen it decline over the years, but it kind of gives us a sense of false security that, we're going to address it through this. But if there's other contributing factors, we certainly need to pay attention to that as well. And I remember the testimony last year in a young lady from Jefferson County who, same situation, wasn't a smoker, only member of her family that wasn't, but had lung cancer due to radon. And just wonder what we need from a policy standpoint to be more reactive in that particular situation.
Yes, policy is going to be important, and education is paramount for the community, providers. A lot of providers don't know much about radon. We're trying to get the message out there.
Thank you. Appreciate it. Thank you, Madam Chair.
Thank you.
And we do have some funding that's local health departments have radon test kits that you can get for free. So you can go to your local health department, put that in your basement, leave it for the appropriate number of days, and then send that off, and you can get that test result back for free to know what your level is in your home.
Yeah, I was going to say, I thought that we had funded an office to look into the radon issue, or within DPH. Is that the funding that you're talking about?
I was talking some federal funding that we have, and I think that program is in a different place than DPH. It was in DPH. I think it's somewhere else now.
Okay, we need to look at that. All right, last question, Representative Duvall.
Dr. Jones and Representative Neighbors, thank you for your efforts, and thank you for these amazing results. This is great. I have a personal story. So my father passed away 25 years ago from colon cancer, and so wow, wish these rates had been higher 30 years ago. But that's great. Thank you for your efforts on that. Also wanted to touch on radon as well. I've been told that the number one cause of lung cancer among non-smokers is radon. I'm not sure if that statistic is correct or not. Maybe you can confirm that. But I was responsible for passing some legislation a couple sessions ago directing funding to improve our public service announcements on radon. That really helped us about 20 years ago. We had a very high radon rate in our basement as well, and it led to us having radon reduction system installed. So I think public service announcements, that was key to us understanding the need for it at that time. Haven't seen a lot of that lately, so I would love to see us ramp that up.
Thank you, Representative Duvall. That is the funding that I was referencing. So we need to make sure that the funds that we've appropriated are actually doing what we set out to do. So thank you so much for this presentation. It's exciting, in the face of a really devastating disease. Cancer does not need to be the number one killer in Kentucky, and we're going to change that. So thank you all. All right.
Thank you.
Now we're going to talk about addiction treatment. And we have some discussion on some buprenorphine administrative regs that are coming up, and I felt like it was important to discuss how to look at what Kentucky's doing. You all can come up, Dr. Murphy, Dr. Ryan, and I know you've got, I think John Inman is here. And then, I don't know, do you all want to, well, you'll wait, okay. All right, so we'll have these gentlemen present, introduce yourselves for the record, and you can come up together. Yeah, and you all, you're gonna have like 5 minutes each because we've got a lot of people. Okay. Good morning. Make sure your green light is on and introduce yourselves for the record. I don't think your microphone's on.
Thank you. Can you hear me now?
Yep.
It's an honor to be here today. I'm Dr. James Patrick Murphy, and I want to thank Representative Moser for inviting me here today to discuss the buprenorphine regulation briefly and how we can save lives together. I am a anesthesiologist. I'm a pain specialist. I'm an addiction medicine specialist. I'm a professor at the University of Louisville School of Medicine. I am the past president of the Kentucky Society of Addiction Medicine. I am currently on the board of directors of the American Society of Addiction Medicine. And I am here on behalf of my colleagues and on behalf of the thousands of Kentuckians who are dying and who are living and struggling with addiction and need life-saving care. And I have some good news and I have some bad news. The bad news is that we have a regulation in this state, the buprenorphine regulation, that is a barrier to care to this life-saving medication. It is outdated. It is not evidence-based. It is not consistent with the standard of care. It is harmful to Kentuckians. The good news is it's unnecessary, and we can repeal it, and we should repeal this regulation. I'm going to give you 6 reasons why. The first reason is what we're dealing with here is a crisis that's unparalleled. Since 2000, 26,000 Kentuckians have lost their lives, mostly young people, in the prime of their life. Rupp Arena holds, what, 23,000? Imagine that. 26,000 deaths. We lose approximately 2,000 people to this disease every year. The last 4 years have been the most deadly in Kentucky's history, although we've had a slight drop in overdoses in the past year. I think a 9.8% drop. That's the overall overdose death rate drop, which is great. We should welcome that. However, not everybody saw a drop. Our black population in Kentucky, their overdose rate actually rose. And we do know that whenever there's a barrier to access to care, it disproportionately affects the minoritized communities. So this crisis is ongoing. It's come down a little bit, mostly because we believe Narcan, naloxone, has been more widely distributed. And that's great. We welcome that. But naloxone, Narcan, it reverses the effects of an overdose. It does nothing to treat the actual disease of addiction. Nothing. It does preserve life, so you can treat them. What treats them is things like medication, and buprenorphine is the most effective medication we have for treating opioid use disorder and preventing overdoses. Okay. Reason number 2, it is a disease. Addiction is not a moral failing. It's not a choice everyone makes. It's a disease. It's like diabetes, for example, or lung cancer we just heard about. It's a disease, and diseases usually involve an organ that is damaged, and there's symptoms, and there's usually treatments. Well, in this case of addiction, it's a part of the brain called the midbrain. It's a subconscious part of the brain that controls some of these urges that we have, actually urges that are important to keep our lives safe and healthy. For example, thirst. Those of you who have been sitting here for a while and have not had your water, maybe you're getting thirsty. Well, imagine in the summertime, you're sitting out there in the hot sun, very thirsty. It's uncomfortable, and you finally get that drink of water. It feels good. It tastes good. Well, that's part of your brain doing that. That's the midbrain. That's the reward center in your brain. And that's the part of the brain that is damaged in addiction. So it is a medical illness. Number 3, we have treatment for this. We have a very effective treatment. Okay? Here's how it works. Buprenorphine is not a powerful opioid. It's a partial opioid. It has what we call a ceiling effect. It's not risk-free, but it's not methadone, and it's not some of the other opioids. People can take it once a day. It covers that part of the brain, treats it kind of like a diabetic taking insulin, and it calms down that part of the brain so that people can think more clearly, can get the care they need, can function in their lives. It's incredibly effective medication. And that's reason number 4. A month ago, Dr. Nora Valco, who is the director of NIDA, she's the top addiction scientist in the country, if not the world. She was at the University of Louisville. She gave a keynote address, and we gave her an award. She's a hero. She has said that we could lower the overdose death rate in this country if we had universal access to buprenorphine. She said we could lower it by 50%. We could cut it in half. Think about that for a second. I just told you 2,000 people die every year. And this medication, just this medication could cut that in half if we had universal access to it. And the reason number 4 is that we have barriers to that access. And this regulation is one of those barriers. And the barriers to people getting this medication are economic, they are stigma-related, and fear-related. And this regulation contributes to all of those. The regulation is not evidence-based. It is not the standard of care. It requires things that are not necessary for patients to get this medication. And they're expensive. Number 2, just the mere presence of this regulation is stigmatizing. Think about it. I mentioned diabetes. We have lung cancer. Other diseases, hypertension. Think about it. There are no separate regulations for these diseases. So having a separate regulation stigmatizes it. Why is it so different? Why are these people treated differently? Why do we look at them differently? And the third reason is fear. The existence of a regulation that doctors have to follow that they don't really always understand. I mean, we read medical textbooks, we look at charts, we do research. We don't really make these regulations or even know how to follow them sometimes. But if we stray, we're fearful that we'll lose our license and our livelihood and our ability to care for people. That is real fear, and that is one of the major reasons why there are so few doctors willing to prescribe this medicine in Kentucky. Again, a medication that Dr. Valco said could lower the overdose death rate by 50%. Number 5.
Dr. Murphy, you're at about 8 minutes. So if you can maybe get to the part of the regulation that you are seeking to change.
Yes, I will.
Okay.
Thank you. Number 5, what happens here is that if we do away with this regulation, it's still a controlled substance. It's still a Schedule III controlled substance. It'll still be regulated. It's not going to be the Wild West. It'll still be regulated. And there's also already a regulation in place that will that will take care of all controlled substances, and buprenorphine would be controlled by this regulation as well. It's 201 KAR 9260. It would still be a controlled regulation, but not a specific buprenorphine regulation. Why is Kentucky one of the few states that has a buprenorphine specific regulation now? We are an outlier. The regulation is outdated. It is unfixable. It is harmful and needs to be repealed. And number 6, the last reason I'll give you, there are 6 people that will die today, of an overdose. All 6 of those deaths are preventable. They're all people, and there's going to be 6 tomorrow. On the average, we lose 6 people. We need to do something about that. Repealing this regulation would help do that. And the last metaphor I'll give you, and this will be brief. I mentioned thirst. Well, and those of you who may like to travel have been to, maybe Death Valley before. It's a beautiful place, but it used to be a sea. It used to be an ocean. And it's no longer an ocean. Now it's a desert. There's sand and there's salt there. Well, imagine you're going through that, and you're just literally dying of thirst in the hot sun. You're not concerned about, nor should we be concerned about, putting a patch on a hole in a boat. What these people need, what the person needs is water. They need nourishment. They need care. Buprenorphine is like water to this disease. This regulation is a barrier to that care. You can do something about it. Please help us do something about it so people can get the care they need, this life-saving care. Thank you.
Okay, thank you. And I think for historical purposes, the committee should know what the federal regulations are. There were X waivers that limited the number of patients that a physician could treat with buprenorphine. That has been lifted, and that's what's different. We're seeking to align Kentucky with the federal regulations. So thank you. Dr. Ryan.
Thank you. Good morning. Thank you, Pat. I'm Dr. Sean Ryan, for those of you I don't know, and have been around for a while. Born and raised in Lexington. Went to the University of Kentucky for my medical degree. Moved up to Northern Kentucky, where I now live. Although I work as a professor for the University of Cincinnati, we never crossed the river because my wife forbade it. I'm dual boarded in both emergency and addiction medicine. I've been a lot of positions in my life, including the chair of quality and patient safety for Mercy Bon Secours in the region of Cincinnati. And that's where I started down this track of trying to help folks with opioid and substance use disorders. I've served on almost every committee you've ever heard of in the entire country because I have a compulsive inability to say no to try to help people. I think it's part of our training. And I'm currently the Federal Advocacy Chair for the American Society of Addiction Medicine, so I spend a lot of time in D.C. Doing these kind of federal things like the X waiver. Where I work currently, primarily at the University of Cincinnati, is I'm the Chief Science Officer of Brightview. If you're not familiar with Brightview, it's one of the largest entities in the country regarding substance use disorder and mental health treatment. Founded it over 10 years ago. Very simple concept. Follow the science of the biopsychosocial model and be good, compassionate care delivery individuals. Pretty simple. Didn't really know that was that foreign of a concept 10 years ago, but evidently it was, because now we're in 7 states with almost 90 sites. And so it really wasn't the intention, but that's my purview of things now, so I have a little bit of a broad perspective. I wanted to respect Dr. Murphy's testimony and say I agree generally. It is literally almost impossible to write it. If you asked me, having done a lot of this work, to write a regulation that said you shall prescribe this many milligrams on Tuesday and on Thursday you'll do the follow, I couldn't do it. And that's me having all the expertise and the history in the world. I couldn't do it because it's almost impossible given what we see as practitioners, where people will come in and they're just like, I don't know, I bought it from the Shell station and it has this random stuff I've never even heard of. And so that variance makes it very challenging to write the medical prescribing part of that regulation. That's one part of the issue. In contrast to that, however, what we do know is that medication is not the only thing that people need. And that's what we're really struggling with. I agree with Dr. Murphy in the fact that we should look at the section of the guidelines, the regulations, that tells prescribers how to prescribe. But what we need to also recognize is that the level of care that requires the whole biopsychosocial model, which is the correct thing to do and is laid out very clearly in the ASAM 4th criteria, require other things. And how do we do that? Well, that's a different question. It currently is somewhat covered by the KVML regulations for OBOT prescribing. And that's the sensitivity we have to balance here, is Dr. Murphy's not going to prescribe the wrong thing. We really probably shouldn't tell him what to do on Tuesdays, to be honest. Or me either, because I've seen enough complicated patients in every setting you can imagine, hospital to ER to the street, in all honesty. But we do need to work with the KVML and the legislature and, most importantly, the payers and the other regulators in the state to really align what is going on with what needs to happen with the new biopsychosocial, or the biopsychosocial model that's demonstrated by the ASAM criteria. Where am I really going with that? I'm going to be very clear. It will not matter what regulations are changed, written, or appealed if the insurance companies do not abide by that. It won't matter. There won't be any Dr. Murphy. There won't be any Dr. Ryan. Because what they're doing today, and you all are aware, is cutting rates, slashing unilaterally, and making decisions without any science, without any alignment with the ASAM criteria. So there won't be any access for Kentuckians. It's already declining. Brightview is declining. Other entities are declining. You all are aware. So we can talk about this, and it should be We shouldn't be told how to prescribe what milligrams, and I can elaborate on that at a longer time in another place if you all wish. But it won't matter if these insurance companies keep going the way that they're going. And I will say, one other line on this topic, which is challenging, is if we don't have any guidelines or guardrails, what will happen are telehealth pill mills. It's already happening, period. They are just seeing people for 5 minutes, doing no oversight, no ancillary psychosocial services, nothing, and most likely violating both the current and future KBML regulations as well as federal law. And nobody cares, especially the payers, because they can pay $50 to see that patient because they see him for 3 minutes from California. These are not, most of them, Kentucky physicians doing these kinds of things. And so the real problem today is not only what Dr. Murphy is saying is these regulations are way too prescriptive, but they won't matter if we don't have access for Kentuckians to get substance use disorder care, and that's what's happening. I hope that was succinct. I have a lot more written down, but I summarized for the sake of time.
Thank you. Yeah, I appreciate that. Yeah, we are aware of the issue with the MCOs, and it's a whole big problem. The treatment facilities are not regulated under our Certificate of Need program, and we also have no prior authorization for the Medicaid population right now. So we're starting to see this explosion in Medicaid utilization, and consequently, the MCOs are cutting contracts and reimbursement. So that is a very, very short version of what's going on, and I know it affects our treatment providers who are following strict quality standards. So thank you for what you're doing. Thank you for being here. I think this is a good discussion, and certainly we're going to work with the Board of Medical Licensure, who I want to hear from right now, and we'll hopefully get this straightened out. So thank you.
Representative Mosier, one final point on what you just said. The way that that's being handled, because some of the inappropriate services were used, is going to cost more in the long run.
Yes.
Right. If you delete the effective, cost-effective, and not that expensive outpatient care out of the system, we'll end up where we were 10 years ago, all in the hospital and all in the emergency department. I don't need to see Groundhog Day. I was there. Mm-hmm. And that's what's happening, is we are raced to the bottom, and it will cycle back, and the state's bucket will be the one that gets hit, because people will be back in the hospital, not able to see Dr. Murphy for the quality care he provides.
Yeah. Thank you. This is an important issue.
Thank you.
Okay.
I'll say one more thing. More information is available at the website for the Kentucky Society of Addiction Medicine. The website for the Kentucky Society of Addiction Medicine. I invite you to go there. Thank you.
Thank you so much. All right. I'll invite my friends from the Kentucky Board of Medical Licensure. Please make yourselves comfortable, introduce yourselves for the record, and proceed. I would say I'll give you equal time, but we're never going to get out of here.
Fine.
So if you can, speed through this, I would appreciate it.
Well, I'm Mike Rodman. I'm the Executive Director of the Board of Medical Licensure.
I'm Leanne Diakoff, General Counsel with the Board.
I'm William Chase Thornberry, Jr., the President of the Board of Medical Licensure.
Go ahead.
The last time I was here, for informational purposes, for those members that weren't here, we were in 2017 and 18 discussing telemedicine. This is through Representative Riley's work, and then later Senator Alvarado. That became a national model for health delivery. And eventually I was asked to come to the White House to help them prepare their COVID response based on the work that you all have done. Today I'm here in a professional capacity to represent the board. I have a brief statement from the board to help those members that have not had as much experience working with the licensure board. Chairwoman Mosier, Chairman Meredith, thank you for allowing me to speak on behalf of the Commonwealth Board of Medical Licensure today. I'm here to provide insights on the board's ongoing review of potential amendment of its regulation regarding the acceptable and prevailing medical practices prescribing buprenorphine, amendments which will increase access to patients and improve care for those struggling with the opioid use disorder in the Commonwealth. The General Assembly established the Board of Medical Licensure in 1851 with the mandate to protect the public and promote the welfare of citizens of the Commonwealth. And after 173 years, the board remains steadfast in fulfilling this mission. The board is composed of 17 members, which include the highest level of medical leadership in the Commonwealth, drawing upon the expertise of Kentucky's most respected physician servant leaders. Collectively, the board members and executives bring 470 years of combined experience, and this ensures that decisions are deliberate, balanced, and between patient care quality, public safety, and the regulatory compliance. The legislature has mandated that the board promulgate regulations to guide the physician's prescribing of controlled substances such as buprenorphine. Since the inception of the board's buprenorphine regulation in 2015, the board has pursued a careful balance between the access to treatment and implementing appropriate safeguards to prevent misuse and drug diversion. The board's regulation has undergone periodic updates over the past decade, and each revision has sought to adapt to evolving clinical experience, evidence, and the best practices considering our challenging history with opioid misuse. With the passage of the Consolidated Appropriations Act in 2023, specifically Section 1262, the federal government removed the ex-waiver requirement for prescribing buprenorphine. This change aims to improve access for individuals with the opioid use disorder, and as a result, it is a timely opportunity for the board to undertake a review, in part to update its regulatory text to align to these changes. The board's process for its current review of its buprenorphine regulation goes well above and beyond the standard process for all other agencies of the Commonwealth. It's important for the committee to understand that we have been actively working on this since March. This comprehensive review continues, and the board has not filed an amended regulation as yet. Our process began in 2023 with an immediate notification of licensees outlining the circumstances surrounding the ex-waiver removal and the board's interim position until work on the regulation could begin. At that time, the board announced its intention to conduct a comprehensive review of the current regulation. In March of this year, the board convened a work group of subject matter experts. This included the then president of the Kentucky Addiction Medicine Society, the board's longstanding addiction medicine consultant, also a former CISAM president, senior administrators, the general counsel, and myself representing the board leadership. This group brings several decades of regulatory experience and addiction medicine expertise to the process. Over the course of 2 months, the work group conducted an exhaustive initial line-by-line review of the current regulation and created an unrefined draft of potential revisions. This first draft was forwarded to key stakeholders, which include the Kentucky Medical Association, the Cabinet of Health and Human Services, Kentucky chapters of the Family Medicine, OBGYN, and Emergency Medicine, to name a few. The board has encouraged and facilitated the constructive feedback of our stakeholders, heavily relying upon their expertise and viewpoints to drive improvement. Over the summer, the board received 56 categorized comments on the draft from 16 individuals and interested groups. At present, the work group is completing its study of each partner comment and recommendation. The group has met 6 times thus far, and I anticipate it meeting at least 2 more times. The committee should understand that these deliberations are a refined, line-by-line, word-by-word review of the regulation. The assessment and revisions process includes a thorough examination of existing practice, a thorough literature review, consultations with various experts, and the drafting of potential revisions for the board's consideration. It is my expectation that the work group will forward its proposals of the amendment to the full board for discussion and action in December. Upon review, the full board will deliberate and choose whether and what, if any, proposed revisions should be implemented. And once the board has acted, it will file the regulation for amendment through the normal regulatory process. And of course, the committee understands at that point and well appreciates the entire public comment period will begin anew. In closing, I want to emphasize the Board of Medical Licensure is a deliberative body, and revisions of the buprenorphine regulation is part of that careful, thoughtful, and deliberative process. The removal of the ex-waiver presents an opportunity to update the regulation in a manner to enhance access to treatment while maintaining the safeguards to the Commonwealth. The Board remains committed to transparency, and will consider feedback from all stakeholders before filing a proposed regulation, and after those proposals are filed, we'll act. The board must make decisions based on the realities of the Commonwealth, not idealized scenarios. This process reflects our effort to be both realistic yet practical. The board remains dedicated to providing practical guidance to our licensees while recognizing the importance of a balanced access to essential treatment with the need to prevent misuse or diversion. Madam Chairman, Mr. Chairman, thank you for this opportunity to speak on behalf. This ends the board's prepared statement.
Okay, thank you so much. I really appreciate your work on this. I know how carefully and thoughtfully you go through all of these proposals, questions that individuals have, and you do not have an easy job. I'm married to a physician, and they are very smart people and very opinionated people, and you don't have an easy job. So, I would just encourage you to keep up the good work and work together. I appreciate, you're reaching out to me with questions. I know that we had a conversation back in the summer about a proposed stakeholder group, and that, it sounds like you actually kind of put a group together to look at this without the formality. So that's a good thing.
Yes,
I appreciate your being here, and I know that you'll find a resolution, and that we'll keep talking.
Yes, ma'am. We're working very hard toward that. Thank you.
Thank you. All right. I don't see any questions from the committee, so I appreciate your being here.
Thank you, ma'am.
Thanks.
Okay.
Okay, next we're going to hear an update on a bill, House Bill 50, from the 2021 General Assembly. It was the bill that we passed to align mental health parity in Kentucky, and we haven't heard a report on this, and I just wanted to kind of see where we are and what has transpired over these years since the implementation of this bill. So thank you so much for being here. Just introduce yourselves for the record and proceed with your presentation.
Thank you so much. My name's DJ Wasson. I'm Deputy Secretary at the Public Protection Cabinet.
I'm Angie Rayleigh. I'm the Health and Life Director.
I'm Kelly Kelly, and I work for the Market Conduct Division.
And thank you so much for having us here. As a chair said, we are here to give you an update on the annual report that insurers are required to file with the Department of Insurance by April 1 of each year. This is the report that relates to mental health parity. As a little bit of background, the mental health parity law really deals with limitations on care and requires that any limitation imposed on a mental health or substance use disorder benefit is no more restrictive than that imposed on a medical surgical benefit. So it's comparing mental health substance use disorder to medical surgical benefits and really trying to level the playing field. So there are two types of limitations in the law. One is quantitative treatment limitations. Those are numeric, things like copays or visit limits. And then there are non-quantitative treatment limitations, those non-numeric limitations like step therapy or concurrent review or formulary design, anything that would limit the scope or duration of a benefit that doesn't have a number attached to it. So these annual reports focus on those non-quantitative treatment limitations. And they are extensive. They discuss any limitation that an insurer would impose, how that limitation was developed, how the processes are put into place, and then it goes through an analysis to show how that limitation is in compliance with the parity requirements. So, for example, if somebody was in the hospital seeking mental health treatment and had been approved for 5 days but needed to extend their stay, and if an insurer has to review those additional days before providing coverage, that is a non-quantitative treatment limitation. And we would have expected to have received a report from the insurer identifying those processes. It goes, like I said, pretty in-depth. It discusses how the review was developed, when it's triggered. Is it based upon a specific number of days and average length of stay? Is that trigger based upon clinical guidelines, those types of factors and standards used to develop the process. And then it describes the process. It describes it in writing and in operation. And it describes it for mental health, substance use disorder, and medical surgical benefits. So it would explain, is there a provider manual that if a review request comes in, how is that determined? Who reviews it? So that's the written portion. Then it would explain, the report would explain how that was tested in operation. Were claims reviewed, were appeals reviewed to ensure that the limitation on mental health and substance use disorder was no more restrictive than the limitation on medical surgical benefits. So really leveling the playing field and somewhat of a self-certification of compliance with the law. We have received those reports. Every insurer has filed for this year and in previous years. We look at those reports for completeness. Are all the fields responded to? We look at them for obvious red flags to parity law. Then what I would then add is that in September of this year, the federal government has issued their final rules on how to perform a deeper analysis of that. We're training on those rules right now, and we'll be incorporating all of those standards into our market conduct exams so that we can then go back and pull samples and test the self-certification that the insurers have sent. So that was a very brief update, but in the interest of time, I'm going to pause there and answer any questions you may have.
Okay. I don't see any questions. Do we have any questions from the committee? No? Okay. So generally speaking, and to summarize, I guess, are you finding, that our healthcare, our insurers are complying with the law to align coverage for mental health treatment as they would any other medical condition?
I would say, generally speaking, yes.
Mm-hmm.
Again, this is a comparative analysis. So if there are questions or complaints, we would investigate that deeper. But as our review of the reports has shown, yes, we're seeing compliance with parity.
Okay. All right. Well, thank you. That's exactly what the point was of the bill. We do have one question from Senator Douglas.
Yeah, I just have one quick question. You mentioned some red flags to compliance. Could you help me with just a few of those red flags?
Sure.
Or describe them that you're looking for, please?
I think red flags would be if there was if there were differences in the standards. We looked at medical care guidelines on the medical surgical side, but we just had a flat number of days on the mental health substance use disorder side in the example I gave. That would be a red flag. Why is there a difference? So we would try to dig further into that. Does that help explain a little?
Is that the only red flag, or do you have any others?
No, I think there would be several red flags. So I think differences in how the factors would be developed. I think, again, on the quantitative treatment side, we would certainly look at differences in cost sharing to see why. Usually if we see a difference in how a limitation is being imposed, who's reviewing that limitation, we would dig into deeper and say, why is there a difference? Help us understand that difference. So those are kinds of the red flags. When you see an obvious difference on how a mental health substance use disorder is being treated versus a medical surgical treatment. Or if there's a limitation imposed on a mental health service, substance use disorder benefit and not on the medical surgical side, that's another red flag.
Okay. Thank you very much. I mean, obviously being in the healthcare space, I get it, but I think there are a number of people who think a little bit differently, and I appreciate that answer. Thank you, Madam Chair.
Of course. All right. Senator Fromeyer.
As I was trying to read through the conclusions in your report, what I'm trying to wrap my head around is some of the input that we've received from a number of constituents that it's very difficult to receive the mental health care, perhaps limitations of facilities, or maybe even having to get prior authorization And if you're dealing with mental health challenges, that's going to be a real challenge. What does your research show? Can you provide us any analysis that you've done of data of the length of time when the service is prescribed and then it's received? Is there any research done on that?
So that's what we're just starting into. That's the federal rules that giving us that guidance to dig deeper into those. So I think we will have some information about that. Otherwise, what we would have would be very specific complaints, but not a very broad picture, right? Helping out one constituent, but not seeing it across the industry. So that's what our market conduct exams will be looking at in the future.
And does that actually also include, are there a number of facilities available or the quantity of facilities available based on the number of prescriptions that are or are not being filled? Do we have the right amount of facilities?
So network adequacy is what we would call that, and that is certainly an issue that is part of this analysis, yes. Yeah.
When will we receive the important?
Let me get back to you on a time frame on that. This is a very complex review because we're looking at multiple insurers, their mental health, and their medical surgical side. We're looking at multiple treatment limitations. So this is very in depth, and it's going to take a while to complete. So let me get back to you on that answer, if okay. Thank you.
Okay. Thank you, Representative Whitten. Do you have a? Oh, okay. Oh, Wilner. Okay. Thank you.
We're twins, so it's okay. Thank you for the presentation. And a quick, I hope, two-part question is if a consumer, a patient or a provider has questions or concerns about parity in behavioral health, where can those be reported? Because that's something I hear a lot about. And then also, when you're reporting these, are you considering like prior authorizations in behavioral health the same way that you do, like comparing for behavioral health versus purely physical health?
Certainly. So yes, consumer complaints can be filed with the Department of Insurance. We have an online complaint form. It's on our website, but I'm happy to get you that information, and we'll certainly look into those specific complaints and concerns. And yes, prior authorization falls under, again, what we'd call a non-quantitative treatment limitation. So that is something that could be a barrier or a limitation to coverage. And so that's part of a mental health parity review. Yes. Yes.
Okay, thank you. And Senator Berg.
Thank you. Little tangential, but I have been in the last 6 months hearing from some mental health care providers that they've actually received communications from some of our HMOs that if they go out of network, they will be reimbursed at a higher rate. Yes. Yes. Do we have something to stop that type of behavior in this state?
I'd have to know more about why that rate was higher. What does that?
Because it would be paid by the subscriber, not the insurance company.
So I would answer, I don't know how to stop it. I think we certainly have a method to investigate that and see if it violates any of our current laws, and that's something that we could do.
And do we need a law to make sure that insurance companies aren't allowed to do that?
I would defer to you on that question.
All right. Thank you. Thank you.
Okay. Thank you, everyone. I appreciate your being here today. And we may have some questions ongoing, but I appreciate your coming here and your report.
Thank you.
Thank you.
Thank you.
Okay. And finally, we have a great panel discussion on medical cannabis and the program that is being implemented. But first, I am thrilled to have Dr. Shanna Babylonis here with us today. She is an extraordinary researcher at the University of Kentucky, and we will have an update on the research that they are conducting at the University of Kentucky after we established the Cannabis Research Center in, I don't even know what year that was, 21?
22.
22. Yeah. Okay. All right. Thank you for being here.
Thank you so much for having me. Good morning.
If you could just state your name for the record.
Sure. Shayna Babylonis, and I am the director of the UK Cannabis Center and associate professor in the College of Medicine. So I'd just like to present some highlights from the Cannabis Center and on our progress. So since the center has been established, we've received 2 federally funded grants, one for $2.8 million and one for almost $130,000. And I submitted a additional grant. It is a almost $2.9 million grant, and it will be reviewed at the end of the month, so fingers crossed. We have also developed a collaboration with Johns Hopkins University. So this team is recognized as an international leader in clinical cannabis research. And we held a 2-day research collaborative meeting at UK in May of 2024. And in that meeting, we designed and planned a collaborative NIH grant. And we proposed to submit that in February of this coming year. It's a 5-year project, $3 million budget, and UK will serve as the lead site, and I'll serve as the lead investigator for that study. We have also submitted our DEA growing license, so that was asked of us in the original legislation. We've established an indoor growing facility with full security at UK, and we are waiting on the DEA response, and we hope to know more, hopefully by the end of the month, on their decision. And then we'll also know the final federal DEA decision on cannabis rescheduling in early December. And so we'll know if it is going to remain Schedule 1 or it will become a less restrictive Schedule 3 drug. If it becomes a Schedule 3 drug, that would help us with this growing project. But even if it stays Schedule 1, we'll have that licensure in place. We are also ready to launch 2 clinical trials. We just received final approvals for our metabolic health study, and we are on the finish line to be able to start our cancer trial. And so I am leading the cancer trial along with Markey Cancer Center, and we are excited to have this study about to launch. It'll be the first of its kind, allowing outpatient dosing of a Schedule 1 drug for cancer patients. It's a double-blind, placebo-controlled trial with 3 active arms of cannabis dosing and 1 placebo arm. And it's also the first of its kind because it will look at daily dosing for over 4 months. So a lot of studies that are looking at cannabis for cancer, I'm sorry, my mic keeps cutting out, are short. So they're only dosing for like 2 weeks. And so this study is really looking at, let's look at this on a long-term basis. We know that any medicine probably won't help over a 2-week span. Let's look at the cancer trajectory over 4 months and get a baseline ahead of time and then follow them after their dosing is completed to see if there's any adverse events after they stop. It's a very large-scale study, and we're very excited to be conducting these trials. We've also completed about over 10 cannabis projects. We've done human laboratory trials. We were granted a grant to collaborate with Indiana University, and we have completed that project. We have also administered 5 seed grants to UK faculty, all which were completed. And 1 NIH grant proposal was submitted from those projects. We've done analytical chemistry projects. And in addition, we're always holding symposia and webinar series on cutting-edge cannabis science that's open to the public. And so I'd just very quickly like to share some top-line data from 2 exemplar studies. So the first is a study regarding cannabis and fetal and maternal health. This is conducted by Dr. Kristen Ashford, pictured here. And then the rationale of this study is that in states that allow cannabis use during pregnancy is increased. And so this team did a chart review at UK Healthcare and looked at live birth pregnancies over the past 5 years, so approximately 24,000 infants. 7.8% of pregnant patients screen positive for THC or the active ingredient in cannabis. We can continue to track and monitor this to determine how cannabis use policy will impact those rates. They also enrolled roughly 60 pregnant persons in a study, and they recruited people who were using during pregnancy. 60% of those enrolled continued to use cannabis during their pregnancy. And of those individuals who used during pregnancy, 85% were using every other day of cannabis. Over half were using cannabis daily or multiple times per day. Unfortunately, 76% rated cannabis as safer than prescription antiemetics. And most did not understand the current Kentucky cannabis legislation. They thought it was already legal in Kentucky to use it. Our next steps in this project are to submit NIH grant applications, again, to continue to monitor the impact of cannabis policy, and then look at a series of studies looking at cannabis impact on maternal and infant health outcomes. The second study is a drug misuse study. It's an opioid and cannabis trial that I've conducted. The rationale is that animal studies have indicated cannabinoids can help increase the pain relief provided by opioids and decrease or not alter the abuse liability of opioids. This was a 5-week inpatient study, and we gave the participants metered doses, controlled doses of opioids, cannabis, and we also combined those. Again, this is a gold standard double-blind placebo-controlled randomized study. And on this graph, on the left, you see the rating of the question, how much do you like the drug effects that you're experiencing right now? And along the bottom, along the x-axis, is time. So BL is before we gave them the drug, and then you see the time action curve of the drug. And this is oxycodone alone, so an opioid alone. This is the data from how much they like the effects of marijuana alone, so a high dose of marijuana. This is their combination. And so what we see is that when we combine those two drugs, the effect is greater and it lasts longer than either drug alone. Similarly, when we're asking how high are you, on all of our measures, we're seeing a really high rate of drug liking, abuse liability when we're putting opioids and cannabinoids together. So I'll summarize quickly and say that cannabis increases the abuse potential of opioids. It doesn't necessarily increase the respiratory depression that we see, so it doesn't make them less safe physiologically. We don't think it primes people for an overdose, but it definitely increases abuse potential. And I'll just say that we are also enrolling in a clinical trial today to look at those with severe opioid use disorder and determine how cannabis affects opioid withdrawal and safety of very high doses. And so that trial is going to start today. Our future directions, we would love to continue with the clinical trial avenue that we have been going. We're really proud to say that we've established outpatient protocols for Schedule I drug administration, and so we have multiple areas of interest for further clinical trials. We continue to submit NIH grants. We're also interested in exploring the pediatric cannabis poisonings. So those are on the rise nationwide. So accidental ingestion of THC edibles like gummy bears and cookies that have THC, it's very dangerous for children, less so for adults. And so some children are requiring intubation, ICU stays from cannabis alone because they're eating like a whole package of high potency gummy bears or eating a whole package of edibles. That's happening here in Kentucky right now with both THC and Delta 8 THC. And so we need to brace for further spikes once Kentucky dispensaries open, and we're interested in monitoring that. And we're also interested in monitoring the public health impact of Kentucky medical cannabis, and then characterizing the Kentucky medical cannabis program and its outcomes. And so I'd just like to thank the Kentucky legislature, the group here, and our funding sources. Thank you so much.
Thank you so much for this great report. Thank you for your work. I worked on this bill, passing this legislation, because I feel so strongly that research is necessary to really understand what it is that we're undertaking. So in that line of thinking, you're beginning to see some results from some of the clinical trials and some of the research that you are undertaking. How's that information being shared and dispersed? And this is a public health issue.
Absolutely. And so what we try to do is we hold a symposium every year to disseminate the information, and that's open to the general public for free. It's held at UK. And then we also hold monthly or bi-monthly seminars that are webinars that are open to the general public and advertise those. And we invite people internationally, nationally recognized figures that are experts in cannabis science to speak to the public and answer all their questions. And so we are trying very hard to make this accessible.
Okay. Yeah, I think that would be really important for the legislature, the members, to have that information. And if there's anything that we can do to help get this information out, I'm open to any sort of recommendations. And then my last question is, so you're seeing some results, and I'm curious, are any of the results and outcomes leading to any thoughts of further indications for use in the medical cannabis program?
Not yet.
Okay.
No. And so our cancer trial and our metabolic health trials are underway with no data available yet. And then the other trials that we have been conducting are not looking toward a medical indication necessarily. And so the opioid interaction study I'm showing is more indicative of harms associated with cannabis. And so the health benefits we're exploring right now.
Okay. All right. Thank you.
Mm-hmm.
We have a few questions from our members. Senator Tishner.
Thank you. I'm curious about this maternal child health study. Is that study complete?
It is.
I'm in front of you.
Okay.
Hi. Sorry.
That study is complete. I think they're analyzing a lot of the data right now, but it is completed. Yes.
You didn't really give us any data. It says that they followed the birth and over the last 5 years. Did that look at brain development of these children who were?
No, not yet.
That study did not.
Not yet. No, they have not done that yet. We haven't been funded for 5 years, and so I don't know at what stage they are in that aspect of the monitoring the infants. But I know that the data that I have in front of you is what came from their primary study.
Are you aware of any studies that exist that look at fetal development, long-term studies for use of cannabis? Or are you guys kind of leading in that study, in that research?
There is a national, a large-scale study being conducted right now, and some of the data are starting to come out from that large study, indicating that there are health consequences for infants and adolescents who have been exposed to cannabis in utero.
Senator Nemes.
Thank you, Madam Chair. I want to state that I'm impressed with how quickly you all have done some of the studies and got up and running. But the chair did ask the question I wanted, and I'm very anxious to see what Kentucky is wanting to do with medical and how it affects doing medical, and not so much of kind of what you're doing right now is at the effect of using marijuana and cannabis. So please keep us informed.
We will. And so we are very excited to look at our clinical trials and to get those launched. And we will hope to report back very soon on some of those results. Mm-hmm.
Okay, and Senator Fromeyer.
I think Senator Tishner kind of addressed the question, but when we're looking at this as well, as we are talking about the medical side, the interaction for the children, I am extremely concerned about that. There continues to need to be education. But you mentioned the gummies and so forth. Relative to what's been authorized in Kentucky, I don't think that we've authorized anything smokable, but is that part of your study? So that's also part of the information that continues to be shared to our Kentuckians about the impact of their behavior, since we do recognize that people are still smoking it. Is that being included so that we're including that in informing our Kentuckians of the potential side effects of their actions?
Sure. So I think it's a dual-fold issue. Smoking is the most common form of cannabis use by far in the United States, regardless if people are using medical cannabis or recreational use. Smoking outpaces other forms by far. And in the study that I showed you, we were modeling an abuse type question. It wasn't necessarily targeted towards medical use for a person who had a condition we were trying to treat. It was a trial designed and funded by the NIH so that we could look at abuse liability interactions, because we know we have an opioid epidemic in the country and in Kentucky, and we know that cannabis legislation is changing rapidly, but we don't know what happens when those two meet together, right? And so the question was more toward, what will cannabis do to someone with opioid use disorder who is actively misusing opioids? What does cannabis do? And the answer is not a great one. The answer is that it enhances the abuse potential of opioids. And so it was more geared towards that question rather than the medical use of it. Now, the study that we're launching today will look at how does cannabis alter opioid withdrawal outcomes? So can cannabis suppress some of the opioid withdrawal signs and symptoms? And then also we'll ask the abuse liability question. When people take very high doses of opioids, what does putting cannabis on top do in someone who has severe opioid use disorder?
Okay. Great questions, great research. I like seeing the future directions, and I'm always impressed by the speed with which you are completing and really looking at some of the questions that we all have. So thank you again for your work, and thanks for coming here today.
Thank you. Thank you all for your support.
Of course. Next, we will invite Sam Flynn, who is the Executive Director of the Office of Medical Cannabis. And I think Scotty McFarland is here and Shelby Lewis. So come up and make yourselves comfortable and tell us all about what is going on with the implementation of the medical cannabis program.
Well, thank you, Chair Moser and Chair Meredith, for having us today, and members of this committee. We're always excited to be here and talk a little bit about this program and how things are rolling out. And we want to go through a short presentation that's going to cover a number of things. First, it's going to talk about where we are with practitioners in this space. Then we're going to walk into licensing, and we're right in the middle of that process right now. And then we'll wrap with ballots and where this thing is with respect to local governments. And then, of course, any questions that you all may have, we're happy to answer. With me today are our Director for Licensure and Access, Nick Therrell, and Shelby Lewis, our Executive Policy Advisor. All right. So a little bit about the Kentucky Medical Cannabis Program, what our mission is. We are the Office of Medical Cannabis. We administer this program with respect to Senate Bill 47 that was passed in 2023, which you are all familiar. And our duty is to implement this program and ensure that Kentuckians suffering with a set of serious qualifying conditions have safe, affordable access to medical cannabis products in the Commonwealth on or after January 1 of 2025. So a little bit about our timeline. So Senate Bill 47 signed into law March 31st. Moving forward, we were given until July 1 of 2024 to promulgate our regulations. We had all of those done by April 18th of this year. And we also worked with some of your colleagues to move up the timeline for medical cannabis business licensing, because we know that if we're not able to issue a license to a business until January 1, 2025, Kentuckians that are applying for their card January 1 won't have access to medical cannabis anytime soon. So we wanted to move up that timeline 6 months. We were able to hit that date, and we are currently wrapping up the licensing process now. On medical cannabis practitioners, July 1st of this year was the first date on which folks could become authorized. So that applies to APRNs and physicians licensed here in the Commonwealth. The Kentucky Board of Medical Licensure, who you heard from earlier today, and the Kentucky Board of Nursing were required to promulgate regulations establishing how these physicians and APRNs could become authorized. They have done so, and those regulations became effective in June. Moving forward, we've had a number of these folks become authorized here in the Commonwealth, and we're doing a significant amount of outreach now, and we'll be doing so over the course of the next year, reaching out to physicians, explaining to them what the process is to get authorized, what the requirements are, how they then become registered with the Office of Medical Cannabis. And it's important that they do that, because if they don't register with our office, they can't enter in certifications which patients need to ultimately apply for their medical cannabis card. So I just walked through those steps. Those are up on the screen here. So it's a simple 3-step process. First, for physicians or APRNs, if they want to become authorized medical cannabis practitioners and write certifications in the Commonwealth, first thing they need to do is apply to their state licensing board. I think it's $100 for an application at KBML or KBN. KBN's is all online. KBML's is paper. Once they have done that and are notified that they've been authorized by their state licensing board, then they need to come to the Office of Medical Cannabis, kymedcan.ky.gov, and register. And they're registering in our online portal. Now, the next step is actually writing the certifications, and folks will be able to do that starting December 1st of this year. Certifications are good for 60 days. The folks will go into our online portal once they've seen their patient in person. First visit has to be in person. They'll enter in the written certification. Once down the road, once the patient is applying for their medical cannabis card, they'll enter in some key information, date of birth, social security number, and that certification will populate. They'll be able to click on it and associate it with their application. And that's how folks will apply for their medical cannabis card here in the Commonwealth. If folks have more questions about practitioners and how they can become authorized and how they write their certifications, there's a ton of resources on our website, again, kymedcan.ky.gov, and we have a practitioner registration guide that's on that site, and we also, again, are hosting a number of webinars, and we encourage doctors and APRNs to sign up for that. This is actually old data, we now have 92 authorized and registered physicians and APRNs here in the Commonwealth, and that we anticipate that number to significantly grow over the course of the coming weeks and months. And we will be putting out a directory on our website so that medical cannabis patients or folks that have these serious qualifying conditions can find the physician or APRN nearest them. So as I mentioned, our webinar series, again, that's on our website, so I don't want to linger on that too long. medical cannabis business licensing and operations. We put out the regulations on January 4th for how these businesses are going to operate here in the Commonwealth. A lot of rules and requirements. Many of those are in the originating legislation. We want to make sure this is secure here in our communities in the Commonwealth, and we also want to make sure that the products are safe, medical-grade products that are tested and safe ultimately for our folks here to consume. Those regulations are now effective, and our business licensing regulations are through the ARRS committee as well. Those are on the page. They're all at 915 KAR if anyone's interested in going and looking at these specific administrative regulations. So, business license types, and I don't have to tell you all because you all voted on the bill, but in the legislation, there are a couple different business types that we are licensing here in the Commonwealth. Cultivators, processors, producers, safety compliance facilities, and dispensaries. This is the entire supply chain. And I want to remind folks that because this is still a controlled substance at the federal level, controlled substance at Schedule 1, all of the medical cannabis has to be grown, processed, tested, and ultimately dispensed right here in the Commonwealth of Kentucky. So cultivators, all of its indoor growing space, we are issuing licenses on those currently. Processors, these are the folks that take the medical cannabis, the raw plant material, and turn it into things like edible products or vaporization or nebulizer products, ointments, things like that. Producers, it's a hybrid of a cultivator and a processor. We're not issuing any of those at this time. Safety compliance facilities, it's a long phrase, but it means testing labs. And we've issued 3 licenses on that thus far. And finally, dispensaries. And ultimately, these are the places where folks are going to purchase their medical cannabis. And I want to linger on this just for a moment. We have designed our regulatory structure not just to fit with the letter of the law, but the spirit of the law as well. We want to make sure that this is a safe environment, that this is a pharmacy-like environment, because this is healthcare. These are medical products. We do not allow food and beverage to be sold in these facilities. We do not allow hemp-derived cannabinoids, vape products that are not medical cannabis products, or anything that would allow an individual to smoke medical cannabis, which of course is prohibited here in the Commonwealth. Again, we want to make sure these facilities are secure and they are providing medical products to our patients and nothing else. Again, a lot of requirements, as I mentioned: physical security and lighting, surveillance, testing, age gating as well. Number of licenses that we're issuing. So 16 cultivators, and we are conducting our license lottery for those on Monday at 2 p.m., and that will be live streamed at the Kentucky Lottery Corporation. We'll be doing 10 Tier 1 cultivators. That's the smallest tier. It's 2,500 square feet of indoor growing space. 4 Tier 2, that's a little bit larger, that's 10,000 square feet, and then 2 Tier 3, and that's 25,000 square feet, which is just a little under half an acre. We'll be doing 10 processor licenses. Again, those will be on Monday as well. And then dispensaries, we're still working through the large volume of applications that we've received, and we will be announcing the dispensary license lottery date at a later date. There'll be 48 of those spread across the Commonwealth, and we'll talk a little bit about the reason for that here momentarily. So, 11 licensing regions. We wanted to make sure that folks do not have healthcare deserts. We wanted to make sure that these dispensaries are spread throughout the Commonwealth so that folks can get access. So somebody from Pikeville is not driving to Lexington for their medication. So 4 licenses will be issued per region, except for the region containing Jefferson County and the region containing Fayette County. And that's because Fayette County and Jefferson County get 2 dispensary licenses because they are our largest population centers. Throughout the state, 4 licenses for dispensaries per region, no more than 1 per county. And again, this is something we heard from the folks that are, our mayors, our county judge executives. One of the concerns early on was, well, we don't want these things cropping up on every street corner. We listened and built that into our program so that no more than 1 dispensary point in any one county. But again, making sure that the drive time to and from the nearest dispensary is the shortest possible for our medical cannabis patients in the Commonwealth. We have non-refundable application fees and non-refundable licensing fees. They are on our website and they are up on the screen currently. I don't want to linger on those too long. This is the timeline that I mentioned earlier. And we received 4,998 applications between July 1 and ultimately August 31st at 11:59 p.m. And I assure you people were applying at 11:59 p.m. So a lot of interest. This is the breakdown based on the category. So Tier 1, 239, Tier 2, 190, Tier 3, 155, processors, 334, safety compliance facilities, 5, and dispensaries, 4,075. With respect to safety compliance facilities, generally speaking, only 2 or 3 of these pop up in any one state. So we wanted to make sure that we didn't necessarily have a initial limitation on these. And so we've now licensed 3 of those labs, 1 in Nicholasville, Kentucky, and 2 in Louisville. Again, our license lottery date for non-dispensary, so cultivators and processors, will be on Monday, October 28th at 2 p.m. Now, we have several very important elections, as I'm sure you all would agree, coming up in 2 weeks. And about 103 jurisdictions have decided to put medical cannabis business operations on the ballot. So every jurisdiction starts from a position of being in this program and allowing medical cannabis business operations. Local governments, pursuant to Senate Bill 47, are allowed to opt out, or they can put it on the ballots for their citizens to decide. 103 have, 53 counties, 50 cities. It's important to note that what folks are voting on. They are voting on whether businesses can be licensed and operate in those jurisdictions. So folks that, let's say they have cancer or PTSD or multiple sclerosis or one of the other very serious conditions listed in our bill, those folks can still purchase medical cannabis in another county, come back to a jurisdiction which is voted to say, no, we don't want these businesses to operate, possess and utilize their medication in their home county. So, or city for that matter. We have created an interactive map on our website, again, kymedcan.ky.gov. These are the counties that have stayed in or affirmatively opted in. Those that have opted out are in red, and those that have both jurisdictions that have opted in and out in purple. Interesting map. All of the ordinances are available online, again, at our website. And then finally, ballot resolutions. So this really tells the story of just how many jurisdictions will be voting on this. Again, yellow is the counties that will be voting on this. Orange are counties that have a city or cities within it that are voting on this. And then red is the counties voting on it and cities are voting on it. So there will be opportunities for folks to ticket split on whether businesses will operate in their city or their county. So a lot of great information there. And again, if any of you all have questions about local jurisdictions in your districts, please feel free to reach out. We're happy to provide any information you all need. With that, thank you for your time. I know I talked a lot and I talked really fast, but there's a lot of ground to cover, and happy to take any questions you all have.
Thank you so much. This was great information. It's exactly what I wanted. I just wanted to make sure that everyone had an update on kind of where we were, what was happening, both on a state level and then locally. I can't wait to see that lottery. Oh my gosh, 4,075 folks have submitted applications for dispensaries and 48 are going to be awarded. Okay.
That's correct.
Yeah, well, I'll stay away from that location that day. All right, we have a few questions. I have a question. I think I heard you say that one of the methods for the processor was looking at vaporizing. we don't have smokable or vapable products being developed, as I understand it. So will this be some sort of nebulizer?
So vaporization products are permitted under Senate Bill 47. So what Senate Bill 47 lays out is that smoking of medical cannabis is prohibited. Senate Bill 47 also allows the sale of raw plant material. So we have prohibited through regulation, again, trying to stay in line with the spirit and intent of the law, prohibited the sale of anything that would allow somebody to smoke medical cannabis from being sold at any of those dispensaries. So setting that aside. The next piece is more to your question related to vaporization products, nebulizers, things of that nature. So Senate Bill 47 does allow vaporization products. House Bill 829, which was passed this past session, made some tweaks to that law. So it does not permit, or so it prohibits, the use of vaporization products by folks that are card holders in any public accommodation, public transportation, et cetera. It very, very narrowly constricts where individuals could vape a product. Essentially, it's fairly limited to home at that level. Really, the law seems to direct or move folks towards that are going to be consuming these towards edible products. And I do want to be clear and touch on one point. The types and amount of medical cannabis that folks will have available to them are decided by their authorized practitioner. So the person that's going to be writing the certification, they can toggle how much medical cannabis an individual can get. So we set a 30-day supply limit. They can write below that. They can write above that. If they write above that, they have to state the reason why, and all of that data is captured by us. The other thing that they're permitted to do is toggle the types of medical cannabis products that an individual can get. So they could say they've seen somebody and they say, you don't really need a vaporization product, you need more of an edible product. So I'm going to write a certification that does not allow you to purchase vaporization products, but does allow you to purchase edible products. I hope that answers your question.
Well, yeah, it does. I mean, it sounds contradictory in the language, and so I don't envy you in trying to interpret that. But it, I mean, raw product. It's vaping is smoking, so we all kind of know that. All right, we have a few questions. Representative Sharp.
Thank you, Madam Chair. As far as the dispensaries, the license for the dispensaries are concerned, what type of controls do you have in place to minimize out-of-state people from coming in and getting these dispensary licenses? My understanding is they're flooding, they're renting a location and then applying 50 times under 50 different company names.
So this is a great question, and actually I think a misconception. So the question with respect to prohibiting out-of-state businesses from applying is something that we looked at certainly at the outset of developing our regulations for licensing and how we're going to structure this. We cannot prohibit out-of-state businesses from applying for medical cannabis licenses. Other states have tried it. They have had their regulations struck down under the Dormant Commerce Clause of the United States Constitution. And that's happened in Michigan, that's happened in Missouri, that's happened in Maine. It's gone up to the First Circuit Court of Appeals, and it's been struck down. So we don't actually prohibit out-of-state businesses from applying for medical cannabis licenses in the Commonwealth. Now, what we do is we limit the number of applications that you can apply and what you can apply for. For example, once you have made a decision that you want to be part of this program, you can apply for one type of business in the supply chain. That's it. So if you want to cultivate, you can apply for cultivation licenses. If you want to process, you can apply for a processor license. You can't apply for both. So that's one piece to it. The second piece to it, we do allow some folks to apply multiple times. So you can apply for a cultivation Tier 1 license, a Tier 2, and a Tier 3, but you can only do that once. You can also, if you're applying for a dispensary license, you can apply one time in each of the 11 regions, and that's it.
All right, so if someone applies 50 times, or we'll say 50 companies apply, and they're using the same return address. Do you have ability to capture that, and what do you do if that happens?
I think I would have to look at the specific circumstances, facts and circumstances, before we make a decision. If they are 50 distinct businesses, for example, 50 distinct LLCs or 50 distinct companies, I mean, for example, lots of different companies use the same, sorry, trying to think of the word. Anyway, their registration where you would serve them process, right? So a whole lot of businesses could have the same registration or same business address, be multiple different LLCs, multiple different owners. So again, I think it relates to the specific facts and circumstances, and we look at all of that. Now, I can tell you that, for example, that folks may try to apply more than one time in a cultivation tier. If they do that, we will accept the first application and deny the remainder. If they apply for one or multiple business types, so they apply for a dispensary and they apply for a cultivation, whatever one was first, we'll look at that one, we'll deny the others. And the reason for that is getting to the heart of what you're talking about. We want to make sure that folks are experiencing a fair process. We want it to be fair for everybody that's involved and that's serious about being part of this business, and we want to make sure that nobody's trying to game the system.
All right, so just to make sure I understand that if you have a bunch of applications from the same address, you're going to physically go through and look at those.
Absolutely. Every application that we have received is reviewed 3, if not 4 times.
Thank you. Thank you, Madam Chair.
Yes, of course. Thank you. Representative Roberts.
Thank you. Thank you, Madam Chair, for letting me be an interloper in your committee today and giving me the privilege of asking a question. Sam, great job today. This is such a huge process, and you guys have been handling it with grace and a lot of transparency, which I'm really grateful for. I have a twofold question, which is, could you talk to us about how many people you think will actually be eligible in the state of Kentucky, because we do have such a restrictive program? And the previous person who testified talked about how many people in Kentucky already think this is the law, and up in northern Kentucky it's even more confusing since we have full adult access right across the river. So could you talk to us about the volume of calls you are already getting and how you expect to handle the volume of calls you may be getting on January 1st as people are trying to figure out if they're eligible? Thank you.
So that is a great question. With respect to the overall number that may ultimately be eligible, that is a moving target because some folks will have a condition that's listed amongst the conditions that are qualifying within our bill, and several weeks, months, years later, they may no longer have that condition. So the number of folks that have one of these qualifying conditions will change. The amount of participation can change. And to your point, we do have one of the most restrictive programs in the country with respect to Senate Bill 47. There's only a handful of conditions that are covered. I think the Board of Physicians and Advisors, which was statutorily created under Senate Bill 47, made up of folks appointed by the Kentucky Board of Nursing and the Kentucky Board of Medical Licensures, recommended to the General Assembly to expand those qualifying conditions to things like terminal illness, ALS, and Parkinson's. That was included in a bill sponsored by Senator West last year. Ultimately was not part of the final version of House Bill 829. Things like that could change. Obviously, more conditions could mean a lot more people that are part of this program. With respect to the folks that are confused perhaps about whether medical cannabis is lawful in Kentucky, currently it is not. It is not lawful until January 1 of 2025. We are doing a significant amount of outreach to folks across the Commonwealth to make sure that we are communicating that to folks. There are some things, to your point, that do confuse folks. For example, the fact that hemp-derived cannabinoids can be purchased at essentially every gas station here in the Commonwealth of Kentucky, and those products do contain THC. So those do confuse folks. I know that folks in northern Kentucky, particularly folks in western Kentucky, where it borders Illinois and Missouri, are impacted by the fact that folks are purchasing adult use cannabis and bringing it back into the Commonwealth and those parts of the state. That is not lawful conduct, and we certainly do not encourage and would actively discourage folks from doing that. With respect to the calls, we are investing in a call center that will not only answer phone calls from folks in the business community and folks that are patients, and to your point, our volume of calls currently and our emails through the Contact Us portal that we have on our website have picked up with respect to patients, but also for law enforcement, so that law enforcement that may interact with folks that are medical cannabis card holders can validate that they do in fact have a medical cannabis card.
Okay, thank you. We have 3 more questions, and I understand if folks need to leave, we are at time, so there's a lot to talk about. Representative Bray.
Thank you, Madam Chair. With so many applications, I would imagine that the your all's restricted funds have exceeded expectations. Can you kind of speak to how much money you all have received through application fees?
Yes. So when we received the charge to implement Senate Bill 47, we were required, it actually is, there's a provision in 218B 140 that requires us to look at best practices in other states, and that's exactly what we've done in setting our non-refundable application and non-refundable licensure fees. So what you'll find is those fees that were on the screen earlier match up pretty much with comparable states, so West Virginia, Ohio, places like that. But with respect to the number of applications and ultimately the number of application fees we received, 4,998 applications. The fees for the different tiers and types are different, but ultimately we received, I think, $27.7 million in application fees, which are restricted funds.
Within House Bill 6, we'd put about $10.3 million towards from the general fund to supplement any kind of funding shortfall. Will those funds be necessary, or will you have more than enough restricted funds to operate?
So we'll certainly, obviously this is a significant amount of one-time funds coming into our program. We are doing applications once. On a going forward basis, there will be 70 plus, almost 80 licensees in the Commonwealth paying fees, not 4,998. So those fees in and of themselves will not be enough to sustain the program going forward. However, these one-time fees do buttress us, I think, over the next several years.
And then finally, with over 4,000 applications and 48 spots, what does the process look like to expand the program? So once you issue the 48 licenses within the defined regions, I can see a day where there's a need to expand or a desire from somebody to expand. So what does that look like?
So that's a great question. It's one of the reasons why we started on the small side, particularly with respect to cultivation and processing. To Representative Roberts' point earlier, the population numbers, the folks that are going to be part of this program, we don't know until we know. And so as that population grows, that's where we can start looking into additional cultivation space, processing space, et cetera. With respect to the dispensaries, we set those up. So again, we're following the spirit of the law, which is to keep this as tight and secure, and that it's not in every single community, but that there are access points throughout the state. If we do get to a point where there's a saturation point of patients, et cetera, then at that point it may be time to take a look at that, but that would likely be years down the line.
All right. Thank you, Madam Chair.
Of course. Thank you. Senator Tishner.
Thank you. I'm curious to know if hospitals will be dispensaries for pain management.
So the way that the law is currently set up, hospitals are not necessarily thought of as medical cannabis dispensaries. So that's not necessarily where these businesses are going to be applying. So I think we may have received some applications from hospitals, but I'd have to check on that and get back to you. With respect to pharmacies, pharmacists are not the dispensers of medical cannabis, and traditional pharmacies, so your Rite Aids, your CVS's, and things of that sort, typically are not getting involved in the medical cannabis space because it's still at the federal level a controlled Schedule I substance. Yep.
Okay. And last we have Representative Fraser Gordon.
Thank you, Chair. I just have a few questions on the consumer level. Is there an anticipated price that a consumer would pay for these, like a price range? And then is it all private pay? And are there any insurances, particularly Medicaid, that will be reimbursing this?
So actually, handling that in reverse order, whether it's reimbursable. So Senate Bill 150, Senate Bill 47, KRS 218B 150 specifically states that government assistance is not available for medical cannabis products, so it will be an individual pay situation, at least for the foreseeable future, until the law changes at the state level or at the federal level or both. With respect to price ranges, we are not, in the Office of Medical Cannabis, provided the authority to set prices in any way for this medication, and so that will be left up to the individual businesses, and will obviously be in relation to the market economics that these folks will be dealing with.
Do you have a price range at all, like based on other states?
No representative.
Okay.
Okay, thank you.
Yeah, sorry, it varies across the states, so I couldn't give you a specific range.
Okay, and the real last question, Representative Callaway.
Thank you so much for that. Thank you for all the information. I was wondering about one of the questions that was asked earlier about the licensing. We have received all those. Is there open records to see what type of what type of applications have been submitted for which tier and all that?
Certainly. So one thing that is we certainly want to be as transparent as possible, and we comply with the Open Records Act in every conceivable way we can. We've received open records requests for applications. One thing that is provided in our law with respect to KRS 61878, I believe it's K, don't quote me on that, but it is in our open records law that we are not required to provide, and are in fact prohibited from providing information related to the internal workings of a business that is applying for a license. And that was a change to the open records law from a few years ago. And so we don't provide the inner workings of a business's that may have applied to us. So they're required to submit some documentation to us about their timeline for becoming operational, how they conduct their business, their standard operating procedures. We obviously don't want to provide that to a competitor in the industry, and so we won't provide that. But we will provide the business name, all of the other information that's within the application. So they'll receive a redacted version of the application, but it'll contain a ton of information.
Thank you. And I was just wondering about what the process looks like if somebody doesn't renew an renew a license going forward. What does that look like? Does that continue to be a lottery?
Yes. So for the foreseeable future, we will have a lottery process anytime that there is a vacant application or a vacant license. So if somebody receives a license and 8 months down the line decide, we don't want to operate in this space anymore, and they forfeit their license or decide not to renew their license, they have to inform us. There's a transition period, so where they offload all of the medical cannabis that they currently have access to, if any, as well as their operations for shutting down their license here in the Commonwealth. And then, of course, we would do a license allocation, as we have for these initial licenses that we've put out, and allow folks to then apply through our portal just as they have.
Thank you. Thank you for grace.
Okay. All right. Well, thank you so much for this great presentation. Thanks everyone for sticking around for this long meeting, but I think it was a great day. Thank you.
Thank you.
And the next meeting is Monday, November 18th at 9 a.m. And see no further business. We are adjourned.